Asthma is defined as heterogeneous disease characterized by chronic airflow inflammation, intermittent expiratory airflow limitation, and bronchial hyperresponsiveness. The exact cause of asthma is multifactorial, involving genetic, environmental, and immune-related factors. Non-modifiable risk factors are factors that cannot be changed but should be recognized to guide management. They include family history of asthma, family history of atopy. Asthma is more common in children than in adults. Early onset is often linked to atopy. Asthma is more common in males during childhood and in females after adolescence. Modifiable risk factors are factors that can be addressed or controlled through interventions. They include allergen exposure such as dust mites, pollen, pet dander, mold, and cockroach allergens, respiratory infections and infestations, air pollution, obesity, occupational exposures to chemicals, dust and fumes, and tobacco smoking, including environmental tobacco smoke or passive smoking. Symptoms of asthma vary in severity and frequency, but typically include cough, often worse at night or early morning, wheezing, a whistling sound during breathing, shortness of breath or dyspnea, especially during exertion, and chest tightness, or a feeling of pressure or heaviness in the chest. Features that distinguish asthma from other respiratory infections include reversibility. Symptoms improve with bronchodilator use or anti-inflammatory therapy. Variability. Symptoms can fluctuate over hours, days, or weeks. And chronic nature, where there is persistent or recurring symptoms despite apparent symptom-free intervals. According to the Global Initiative for Asthma, asthma can be classified based on severity. Mild asthma has infrequent symptoms, less than once a week, or not more than twice a month. FEV1 predicted is below 80%, but above 60%. Moderate asthma has more frequent symptoms, more than once a week but not daily, and maintains control with low to medium dose daily inhaled corticosteroids. Severe asthma has frequent symptoms almost daily, low lung function, and FEV1 is below 60% of the predicted value. Intermittent asthma has infrequent symptoms less than once a week or not more than twice a month with peaks during certain seasons, such as the rainy or cold season. Persistent asthma has frequent flare-ups and symptoms in between the exacerbations that interfere with daily activities like school, work, sleep, or feeding with mostly no seasonal pattern. The Global Initiative for Asthma recommends a combination of clinical history, physical examination, and objective tests to diagnose asthma. History and physical examination to assess episodes of wheezing, breathlessness, chest tightness, or cough that vary in intensity and time. Spirometry demonstrates variable airflow limitation, such as reduced FEV1-FVC ratio and reversibility post-bronchodilator of more than 12% improvement in FEV1. Peak expiratory flow. Daily variability in PEF values of more than 20% suggests asthma. Bronchial challenge tests to assess airway hyperresponsiveness. Exhaled nitric oxide that is elevated in airway inflammation. Allergy testing such as skin prick or specific IgE tests to identify triggers. The Global Initiative for Asthma Guidelines emphasizes individualized treatment based on asthma control and severity. Non-pharmacological management include avoidance of triggers such as allergens and irritants, weight management and physical activity, and smoking cessation. Pharmacologically, a stepwise management is applied. In Step 1, the preferred initial treatment is as-needed low-dose inhaled corticosteroids for Moderol. An example is Symbicort. An alternative is low-dose inhaled corticosteroid when short-acting beta agonists is used. Examples of inhaled corticosteroids include beclomethasone, fluticasone propionate, and budesonide. Examples of short-acting beta agonists are salbutamol and terbutaline. In Step 2, the preferred controller options are daily low-dose inhaled corticosteroids, or as needed low-dose inhaled corticosteroid formoterol. Alternative controller options include leukotriene receptor antagonists such as montelukast and zofranilukast. The reliever medications that can be used are short-acting beta agonists. In Step 3, the preferred controller options are low-dose inhaled corticosteroids and long-acting beta agonist. Alternative controller options include medium-dose inhaled corticosteroids, such as beclomethasone, fluticasone, and budesonide. Alternative controller options include inhaled corticosteroids, plus leukotriene receptor antagonists, such as beclomethasone and montelukast. Short-acting beta agonists can be used as a reliever medication. In step 4, the preferred controller options are medium-dose inhaled corticosteroids and long-acting beta agonist. Add-on options include long-acting muscarinic antagonist, such as tiotropium. Short-acting beta agonists can be used as a reliever medication. In step 5, the preferred controller options are high-dose inhaled corticosteroids and long-acting beta agonist. Add-on options include biologics, such as anti-IgE, like omalizumab, anti-IL-5, like mepolizumab, anti-IL-5R, like benralizumab, anti-IL-4R, like dupilumab, and low-dose oral corticosteroids like prednisone. For asthma exacerbations, the management is prompt treatment with high-dose inhaled corticosteroids, formoterol, or systemic corticosteroids, and oxygen therapy for hypoxemia during severe exacerbations. And that's all for this video. If you find this video helpful, don't forget to like, share, and subscribe for more informative content. Stay tuned for our next video.